So, hi everybody. It's a pleasure for us to be with you for another webinar and to have today Professor Faletra with us to give a presentation about MitraClip, echo evaluation and guidance of the procedure with echo. I will ask briefly to Marcelo to introduce Professor Faletra.
Professor Faletra is the head of the imaging center from Fondazione Cardiocentro Ticino di Lugano. He's one of the most experts in 3D echo and operative echo. It's a grand professor that I admire so much, and in the next minutes we will have the pleasure to learn a little about his experience in using echocardiographic evaluation and guidance for MitraClip. Professor Faletra.
Okay, thank you very much. It's a very pleasure to be among you, to be between you, even in virtual mode, but it's a really very pleasure. So echocardiographic evaluation guidance for MitraClip. It just start with the pre-procedural assessment of a MitraClip, which is a pretty interesting problem to. This is, as you can know very well, this is the first paper, one of the first paper in which Feldman and the other of Everest investigators give us the criteria for doing MitraClip. The criteria was mainly for the echocardiographer, was mainly anatomical. So we should have a coaptation length more than 2 millimeters, a coaptation depth less than 11 millimeters, a flail gap less than 10 millimeters, and a flail width less than 50 millimeters. As every one of you knows, this was almost a realistic criteria in the real world. Indeed, this criteria was followed because they just compared two groups of mitral valve, surgical and percutaneous repair. But assessed in this way, just remember how difficult could be, for example, measure the wide flail with 2D echocardiography. This is almost impossible to be precise. Indeed, and then another point was that this was a single clip strategy. Indeed, the Everest criteria and the real world are completely different. This is a paper made by Olaf Franzen, a very close friend of mine, in which he said the higher surgical repair with the adverse valve morphology, not only P1, A2, P1, P2, sorry, A2, P2 as in the Everest criteria, but just adverse valve morphology. So other morphology, P3, P1 could be, and this is a paper made by a group of Catania and Sicily who extended the use of a percutaneous edge-to-edge mitral valve repair beyond Everest criteria. And what they found, there is no difference in the follow-up of the freedom from death, freedom from grade 3 or more regurgitation, and the freedom from mitral valve repair. So no big difference between people who, between patients in which MitraClip was performed following Everest criteria and people in which MitraClip was performed behind the Everest criteria. This is the real world. This is the real world. Now we have a new device, probably most of you know, the MitraClip XTR, which is a 5 millimeter length more than the previous. My experience says that this is a very make my life easier. So what are the today criteria for MitraClip? Well, I just tell you the criteria we use in our institution, but which are a good sense to, there is no real, what to say, guideline for the today criteria for MitraClip. For example, in degenerative mitral valve disease, our criteria was the age more than 80 years old, because before less than 80 years old could be surgical. Unless you have a high risk for surgical repair, or age less than 80 years old with severe comorbidity. We did make some clip in patients of 70 or 60 years old, but with cancer, with severe renal insufficiency, and so on, just to repair the valve, give to the patient some comfort, and reduce the symptoms. But there are also contraindications. And this has to be, we are very strict about that. Extensive calcifications on free margin of the leaflets. And this is one of the most important contraindication. The area less than 3 centimeters square of the mid-gradient more than 5 millimeters mercury, we are very well knowledge that this two number means that after just the with the one clip may make the stenosis intolerable for the patients. So, or perforation on leaflets. Of course, we cannot put the MitraClip when the leaflet is perforated, or if you have endocarditis or rheumatic valve, mitral valve disease. These are our contraindications. We can discuss after about this contraindication. Indeed, so we morphologically, if we have one valve with degenerative mitral valve disease with more than one prolapse, P1, P2, P3 prolapse, or even with the Barlow disease, we do MitraClip. Of course, there are some expectations. But this is the only paper I found that by Jeremy Taden from Mayo Clinic, who correlate the morphology of the valve with the reduction of the pressure into the left atrium. And what they found was if there is no flail, there could be a V wave could be reduced, but is much more reduced if you have a flail. And this is not surprising, because if you have a flail, you just clip in the position of the plate, and usually you succeed. Or if you have just one jet or more than one jet involving more scallop. Of course, if you have just one jet, it's easier to predict that there will be a good results with the V wave going down. If there are more than one jet or more than one scallop, it could be more difficult. But why I showed you this paper? Because in this paper there is another criteria, which for me is really very relevant. And this criteria is this one: the resolution of the echocardiography, or if the image is good or not good, in other terms. Because if the image is good, the results will be good, more good than if the image, because MitraClip is made by echocardiography. What the interventionists do is just move the hands and clip the valve, but without the echo, they cannot do nothing. So this is in my opinion, a very important criteria. So just let's go to the functional mitral regurgitation. In these cases, we do not have the age because you can have also age less than 80 years old, but with comorbidity and of course eye surgical repair. But this is not anymore a criteria because our surgeon does not try to do not operate a single valve with a functional mitral regurgitation. Of course, if the patients need the bypass surgery, there is no story. Make the bypass surgery and then make the repair or the substitution or the replacement of the valve. Otherwise, we actually do not have any morphological contraindication for. The only problem that we have is ejection fraction less than 20. All of you know the mitral affair at the coapt. Well, when the left ventricle is at end stage, probably we do not improve the survival of the patient. But believe me, we improve the symptomatology. Symptoms of the patients clearly are reduced after 1 or 2 clips. So ejection fraction less than 20 is not anymore a problem for us because we know and we talk with the patients. We know that there not will be an improvement in survival because the survival mainly due to the left ventricle dysfunction, but it will be an improvement of symptoms. We have several cases in which we cannot um, do anything and the patients stay in the hospital for weeks in the attempt with a pharmacological therapy to improve their status, nothing. But when we put 1 or 2 clips, well, the patients stay well and the patient can go outside of the hospital. His or her life do not improve, the prognosis do not improve, does not improve, but what is improving is the quality of life. So that's why we do this. And this is exactly what also Franzen wrote in this paper of European Journal of Heart Failure, MitraClip therapy in patients with the end stage systolic heart failure. And what they found is that there is an important increase in reduce of mitral regurgitation. If you can see here that this is a 4 plus, 3 plus the baseline, well, 4 plus, 3 plus is just very few patients and there is no 4 plus mitral regurgitation. So there is a significant improvement in mitral regurgitation and also in functional class. So, and once again, we know that these patients probably in these patients probably we do not improve their survival, but certainly we improve the quality of life. And this is another point, as I told you before, the gap, there will be no gap in the Evers criteria because they should be just coapt more than 2 millimeters. Well, this is not true anymore because we can also have a gap. In these cases, there is no anymore an exclusion criterion. This is a paper from, if I don't remember, Mantova in Italy, and they just make that MitraClip procedure could be extended to patients with a functional mitral regurgitation who do not fulfill coaptation length Everest criterion and who would otherwise be excluded from this treatment. It is exactly what we do. The only the only problem that we can have is that if you have a massive torrential mitral regurgitation with the ejection fraction which is less than 30%, of course, with this torrential regurgitation, if you reduce the regurgitation, well, the left ventricle which is in a very good position from the hemodynamic point of view, because more than an half of the systolic output is going back to the left ventricle. Well, if you just reduce this this way, preferential way, the left ventricle could not, I would say, contract anymore. It could be some problem. And we do have some of this problem. What do we do? And this is an example. We put the device inside. This is one problem. You see, the ejection fraction was certainly less than 30%. There is a gap, an evident gap in mitral regurgitation. The mitral regurgitation is pretty severe. The pressure, left ventricular pressure, was quite low. And what we do is put an impeller. If you put an impeller, you can sustain the left ventricle, and then you can advance. At the beginning, my concern was about if the catheter of the impeller could interfere with the grasping of the clip, but as you can see here, they do not interfere actually, and the clip was closed, and so in other words, there is no cases of functional mitral regurgitation that cannot be done with MitraClip. No cases at all. This is my first message that I can give you. Then we have an evolution of imaging technique in MitraClip. An evolution of imaging technique, and at the beginning, this was a paper of Silvestri. He was the echocardiographer of Feldman in the Everest one, who described with 2D echocardiography the puncture of interlateral septum, the catheter inside the left atrium, the MitraClip, and then the grasping, and then the transcatheter view for seeing the exact position of the arms perpendicular to the mitral valve, and then the grasping. Well, we of course use 2D echocardiography, but we now have other technique. This is a paper from Gila Perk and Isaac Cronson, but other people participate at this 5 hospital at that time, more than 10 years ago, in which this is New York University, Chicago, Madrid, Paris Bichat Hospital, and the Lenox Hill Hospital. And then you see that the use of real-time three-dimensional transesophageal echocardiography in the procedure, catheter-based in the interventional procedure, not anymore 2D echocardiography only, but also 3D echocardiography. But if you see this paper, only 3 patients underwent to the MitraClip using also, together with 2D echocardiography, using 3D echocardiography. And the images that they showed in the paper was not so good as we expect to be. But after this paper, personally, I wrote several papers in which I can say, come on, we can use 3D echocardiography, not in all the steps, and then we will discuss, but in many steps of MitraClip, the echocardiography will be, 3D echocardiography will be very useful. And this paper, I show images in which we can use 3D echocardiography in every step of the MitraClip with the exception of grasping. In grasping, we use 2D echocardiography. Now we have also the fusion images. Fusion images is a technique in which 2D or 3D echocardiography were fused in the fluoroscopic silhouette, in the fluoroscopic screen. So we have in one screen both 2D or 3D echocardiography and fluoroscopy. And this It's supposed to be, and we will show you many examples of this. It's supposed to help interventionists because the images are a fluoroscopic projection, and the echocardiography adapt at this kind of uh, different projection. And you can see here, for example, this is the mitral valve in right oblique anterior projection, and then you can see P1, P2, P3, and they do. This is what the mitral valve appears in fluoroscopy, inside the silhouette of fluoroscopy with in RAW. And this is the mitral valve in LAO, which appear as we will see the mitral valve from left ventricle, which is exactly the LAO projection. And using the fusion images, we can see the catheter, we can see also the projection, and we will discuss. Just this give an idea of evolution of images. We will discuss more deeply later. And for example, we can see the color Doppler in a fluoroscopy for the first time. We can see the regurgitation without contrast in fluoroscopy, and then you can just put the catheter here on the hole of a mitral regurgitation. And now we have another, this is called the True Vision, which is a very interesting cases in which you can look at the 3D images from different point of life, for different point of life. And this is really very interesting to look, and we will discuss also about this. But now we can go MitraClip step by step. So that's okay for all of you. Sadi, Marcelo, it's okay?
Yes, perfect.
Okay, very good. If you have some question, please interrupt me. This is a very interactive, okay? I don't have any problem, so you can, if there is some questions, please interrupt me at any time.
We can leave the questions for the end, Professor Faletra.
Okay, as you wish. So step by step of MitraClip. Of course, the first step is the transeptal puncture. And just to remind you that the atrial septum is not so kind of membrane which divide the two atria. Atrial septum is a much more complex structure. Is made by septum secundum and septum primum, which is the fossa ovale, substantially. And what is important is that the septum secundum is not the septum itself, but it's an enfolding of the atrial wall. And you can see it's a kind of enfolding of the atrial wall. Wide, so the true atrial septum is just the fossa ovale. So the enfolding of atrial wall is made by right atrial wall, left atrial wall, and inside there is extra tissue, extra cardiac tissue, which is mainly made by the adipose extracardiac tissue. So this is the configuration of the interatrial septum. And this is, of course, have a very big implication because this is the epicardial adipose tissue inside. Because while in anatomy we can easily distinguish with the three-layered structure of the septum secundum, in echocardiography is very hard. So saying that this until here, that this is an extra cardiac space is very hard to believe, but this is the reality. So this is extra cardiac space here, or in 3D echo here. So what does mean? This means, oh, sorry. And we can very well distinguish with MRI. Indeed, with MRI, you can see, for example, here, that this is the enfolding of the left atrial, right atrial wall, and This is the three-layered appearance of the septum secundum. So the fossa valis is the true atrial septum, because if we make a puncture here, you can go outside of that. If you insist, you can go inside once again, but through the extracardiac space. So this is important because the puncture of interatrial septum has to be made, in this fossa valis, which could be large, like in these cases, or medium size, or even small size, So, in other words, this is right and this is wrong. Could be okay. It's very easy. No, it's not very easy, because we do have several cases in which I say, no, you are not in the right position. Do not push, please. Go a little bit down. Do not push here, because you are just pushing of the septum secundum. And unfortunately, they push. Fortunately, in many cases, thanks to the echocardiography, they just push it with a single needles, and when they go back, nothing happened. But can you imagine that through here, there is a big catheter with the MitraClip inside, and then when you put away all of this stuff, probably you have an hemopericardium. So this is important to say. Could we to the echocardiography, and we use usually or 3D echo or 2D echo in bicaval view, in short axis view of the aorta, because these are coordinates for the mitral clip, which has to be superior and posterior. This is a pair in which I just describe the septum and which you don't see any tending here. But my intervention, no, I'm sure I am in the fossa valley, and I'm sure that there is a tending. Well, this was 10 or 12 years ago, and fossa valley. All the puncture has to be within the fossa valley. Never here, because they're not septum. This is, as I told you before, an enfolding of the atrial wall. So, for example, for closure of left atrial appendages, inferior and posterior. For the pulmonary vein ablation, in the middle and anterior. From the paravalvular leak, for the paravalvular leak, lateral paravalvular leak, anterior and superior. But for mitral clip, this is important, posterior and superior. So we have to put the puncture in the posterior and the superior projection. But there is not only. When you have a good fossa valis, a good extension of the fossa valis, you can also make a kind of still site-specific position, depending of you have to clip A1P1, A2P2, or A3P2. If you have to clip A2P2, you can go in the middle. If you have to clip A1P1, this is the position. If you have to clip A1P1, then you can go anteriorly towards the aorta, and this is the position. If you want to clip A3P3, you can go posterior and superior, and this is the position. Of course, this is only theory. because most of the time we are not, it's very difficult to distinguish. What we just do is superior and posterior, and this is probably the best way for making enough room for delivery and moving the catheter inside the left atrium. And this is a puncture that we usually do with 3D echocardiography. This is a kind of left anterior oblique projection and fluoroscopy, and then you can see the tending that you can see here. This is a superior, right superior pulmonary vein, and then you can see how easily is to understand, how easily is to understand this kind of a puncture. Now we use also the site-specific with the fusion images. Just let tell you these images here. Let me explain. You see the catheter is here in superior vena cava. So usually the interventionists go to superior vena cava, and then they felt a kind of motion or feedback of the catheter wave from the superior vena cava goes down the right atrium, and then another feedback when it goes down the fossa valis. But now we can see all of this. You see, this is the fusion images. And so the fossa valis is here, the catheter is here, and this is exactly the position in round 30 degrees. Around 30 degrees. So you have the fossa valis end phase. And then you can see here when the catheter goes down, 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 down until they reach the position. Once it's stable in this position, we ask the interventionist to go in low. Rotate the images in low, and then we have in low the tending, as you can see here. In my opinion, this is the safest method for doing the crossing the septum without any damage and just try to make a site-specific position. Then the next step is the advancement of a clip delivery system into the left atrium. And then you can see here the delivery system. This is the guide wire, and this is the guide catheter here. And you can see the advancement of this guide catheter inside the left atrium. Then you can put out the clip. And this is the catheter, and this you can see here the clip that goes out. Many times the catheter is just go to the left atrium, and then when you go outside the clip can be blocked by the wall of the arterial wall or by the ridge, and then in these cases you can go back. You have to go back just making attention that this is the tip of a guide catheter, not go back to the right atrium. But this could be very easily seen and very easily done with 3D echocardiography, as you can see here. This is once again the new algorithm with the mobile source of light. Some people love this, some interventionalists does not. And then there are some limits that I tell you of this technique at the end of my talk. And this is a fusion image. We use the fusion images when we are a catheter, and then you can see the catheter in fluoroscopy goes down in the echocardiographic images, and then this is the tip of the catheter, and this is the guide wire. And you can see very well that this is exactly what our interventionists want to see. They know exactly now that the tip of the catheter in the right atrium, and they can, without asking, just can go back if they need to go back, then go back, because they know that this tip of the catheter never has to go in the right atrium. And for example, this is quite beautiful images in which you can see the clip in the fluoroscopy, and then you can see the catheter in the echocardiography, and then you can see the clip moving in fluoroscopy. You see crossing the septum and go to the tip of the catheter. And at the end, we just try to steering the catheter towards the mitral valve, which is here. Well, one of the most important thing is the position in the clip delivery system perpendicular to the mitral valve orifice. Has to be perpendicular, because otherwise, if you oblique in this way or this way, the grasping could be very difficult. In these cases, we can use 3D echocardiography. Just tell you that when you use 3D echocardiography, you know the fulcrum of the catheter is in the interatrial septum. So the interatrial septum make the catheter very stable. And we realize this when we start to use the clip for tricuspid valve. Using the clip for tricuspid valve, we don't have any more this fulcrum. So the catheter in right atrium is very unstable. It's much more difficult to clip the leaflets because the catheter is moving. In this case, the catheter is pretty fixed, you see, and what is moving is just the clip delivery system here. Probably the best way to understand that you are perpendicularly to the orifice of left is the fusion. With the fusion, you can see that this is a really very images that show you that the catheter is completely perpendicular to the mitral valve annulus, so they can go down, up, and this is a good position. And then, of course, with the fusion, you can see where is it exactly the point of regurgitation, and put the catheter exactly over the point of the regurgitation. And this is another very good help for intervention. This is another, I just give you a story about this. So make the arms perpendicular to the coaptation line. When we started the MitraClip 13, 14 years ago, was at the beginning, but we still use 3D echocardiography. But at the beginning, we have what we call the proctor. So people coming from the manufacturer say what we have to do, because it was one of the first. And they asked me to do the position of a clip arms perpendicular to the coaptation line using transgastric view, which is pretty difficult, really pretty difficult. In the first cases, I do have some difficulties because maybe the in transgastric view, the heart was not completely parallel to the diaphragm. I was a little bit more oblique, and then to make the short axis view of at mitral level, looking at the leaflets and saying that the arms are perpendicular to the coaptation line was very difficult. So I told him, listen, just I show you 3D images, and then you see if this is good. And of course, if you shoot 3D images, they say, oh, come on, this is better than transgastric 2D transgastric view. Of course it's better. You can see the catheter from right atrium crossing the septum, goes down, and the arm make perpendicularly to the coaptation line. Until this moment, the proctor does not say nothing, and my interventionalist anytime say, oh, give me 3D echo for the position of the arms in the left atrium. And this is another image that I showed you, showing with different light, source of light, with different source of light, the same images. I like 3D echocardiography, but I know fans of 3D echocardiography. For example, for grasping, we do prefer 2D echo. Absolutely, we do prefer 2D echo because it's a more frame rate and more resolution power. And then you can see the advancement into the left ventricle you can be done also with 3D echo. Indeed, the 3D echo could be very useful because when you advance the clip inside the left ventricle, maybe you can rotate a little bit the arms. Inadvertently, you can rotate a little bit the arms. So, but if you use a 3D echo, you see when the valve is open or just reducing the gain, that the arms still remain perpendicular. But for the grasping, there is no depth at all. For the grasping, we use the 2D echo. Just an advice for all of you who use the be certainly that the leaflet, anterior and posterior leaflet, are covered all the arms, because this is the best way for grasping. Otherwise, if the tip of the leaflet is here and it does not cover all the length of the arm, this could be pretty difficult. But if you cover the rest of the arm, so the grasping is very easy, and then you can see here, this is the results with color Doppler. But the secret of all of this is that don't say close until you ascertain that the leaflet is in between the arm and the gripper, but very deep in the clip. And then when you are grasped, you are captured leaflet, you can see the double orifice from left atrial perspective and left ventricular perspective. And then what after the first, but after any clip, what we do is to measure the valve area and the residual regurgitation and the gradient. There are some debate how you can measure the valve area. To be honest with you, this is, in my opinion, is the best method to do this. Because 3D echo from left ventricular perspective, you see exactly, and you can see here, you see exactly the margin of the leaflets, and then you can use this margin to measure 3D echo. Are we precise? There is no gold standard for that. We are the gold standard. So this has to be precise. And moreover, we can have the gradient. So if you have the area more than 2 centimeters square and the gradient less than 5 millimeters of mercury, this is a good result. But there is the residual mitral regurgitation. And this is the point. There are some interventionalists. One of this is the Francesco, my very close friend of mine, Francesco Maisano, other Holland friends, that they want to be precise. They want that no regurgitation occurs after the position of the clip. This is a good intention. I like this, but we have to face with the other possibilities. For example, if you have 85 years old patients, which does not move very much, which from torrential, you just have a mitral regurgitation mild or mild to moderate, let's say mild to moderate, it's a really warrant to risk another clip because you see it's a very easy procedure, but until you have a complication. When you have a complication, not anymore an easy procedure. And for example, one complication, couple times, couple cases, we have a complication that the second clip just make attached to the corte tendine. It cannot be closed anymore. And at that time, I say, oh, come on, we can stop with the first clip, and we can try not the second clip. But, so what do we do of any clip with my interventionalist? We just sit down, stop, calm down, and say, okay, listen to the clinical of these patients, how old this is. Can the residual mitral regurgitation would impact in the survival, would impact, and then at the end we decide. Fortunately, this is a really very good thing. There is no increase of cost making a second, on a third, on a fourth MitraClip. This was a very intelligent point from the manufacturer, because otherwise, if I put one clip and then I put another clip, I have to spend another 10,000 francs for the second clip. I say, okay, you know, this is unfortunate. But in this case, it's the second, the third, until up to the fourth clip, the manufacturer, the cost of the clip is the same. So what do we do with these cases here? Well, with these cases here, we decide to put a second clip with a pretty good results. And what about this? You see, this was a little bit more difficult because you don't know if the clip goes from the residual leak was from here or from here, because the clip was in the central. So it was difficult. So the first attempt was just to change the position. If you look at these images here, you can see that the clip is pretty, not completely in this way, but a little bit oblique. So we just decide to change the position. And when you change the position, and the clip is now here, well, this mild to moderate mitral regurgitation disappear at all. So sometimes could be useful to just change the position without putting another clip. And then in these cases, you can have a good results. How many clips here? Wow. In these cases, which was end stage cardiomyopathy, we just put 3 clips, as you can see here, with a good result. Then we have the detachment of the catheter, as you can see here, the catheter, and the catheter which goes away from left atrium in the right atrium. And this is the end of the procedure. And this is another image that show you another thing. You could be satisfied of the procedure if the 2 clips are side by side in the same position, you see? And then you can see with this true vision with the light post, the light is situated behind the images, and then you can see how the 2 clips are really side by side each other. This is a good position for the clip. You are pretty sure that there will be no detachment in the future. So just take the message to you. The best way of guiding any percutaneous structural procedure, so also the MitraClip, is a smart combination of both 2D and 3D fusion and TrueView. You cannot use just one of this methodology. You can use all of the four methodology, and you decide which is the best image. Sometimes, quite often, the best image is 2D transesophageal echocardiography, just 2D transesophageal. So use this. Don't go to in 3D or fusion or TrueView. So the best combination. But generally speaking, when you need to visualize small anatomical details, for example, grasping, well, you can use 2D T. When we need to have a panoramic view of what's going on, where is the catheter, where is the set, where is the mitral valve, then we can use 3D T. The fusion images should, at least in theory, help interventionists for a better navigation because the fusion images show the soft tissue and the position of fluoroscopic images. However, this is my experience, this is well accepted by younger interventionists, but the most experienced still have some reluctance in using fused images. Most of the time they go back to the 2D or go back to the 3D. The True Vision is very new. Theoretically, it might potentially be used because it increases the perceptions of depth. However, you have to choose the just angulation of the light, on the left, on the right, behind, in front, and so on, and this takes time. And most of the time, as you know, the time is the most precious thing that we have during the percutaneous procedure. Thank you very much for your attention and for your patience.
Thank you very much, Dr. Faletra. Excellent presentation. I think I will kindly ask to unshare your screen so we can open for. I think it's just on the bottom. There's where you share is just unshared. So
stop video, no, stop share. Yeah.
Yeah.
Okay.
Stop share. Yeah. Thank you.
Stop share. Yes. Okay.
Thank you. So we have many people watching you, interventionalists, surgeons, technicians, echocardiographers.
Wow.
So thank you very
All
much.
the Brazilian people.
Yeah, and not just Brazilian, all over the world. But so I'll keep the microphones open. Please,
yes.
if anyone wants to ask a direct question or comment to Dr. Faletra, please just turn your microphone on and ask the question. So when you decide what question would like to ask, I'll ask Marcelo, Max, and Rodrigo, the echocardiographers, some of them that are online here, to make some comments or questions, please. Marcelo, quer fazer algum comentário? Marcelo, Max.
Professor Faletra, it was a wonderful presentation, and
thank you, Marcelo.
Yeah, it's fascinating to see how the advance of the echo with 3D echo and fusion images could help us to provide a better information for the interventionalists, and at the end of the day, get a good, a fantastic result of the procedure. And what is your tip and tricks for the ones who are starting 3D echo? What they need to know to get a good imaging for MitraClip?
Oh, Marcelo, this is
it's tough. It's tough.
Well, I can tell you some tricks. First of all, even during the procedure, you choose many images. Check. Acquire many images for a long time, 3 or 4, 5 seconds. And then you choose the best images that, in your opinion, and in the opinion of your interventionist, could be the most useful.
Okay.
that is because you say sometimes some people told me how you can get these images, but this is my best images that I showed you. I cannot show you the worst images, but I have for one images I have thousands of worst images.
Yeah. And you usually discuss the images before the procedure with your interventionist, yeah, or during the procedure?
Absolutely, yes. Absolutely, yes. We have a meeting before any procedure, which sometimes takes 5 minutes, or sometimes takes longer, in which I show you the images that we do have with the patients and decide which kind of which kind of the number, which if the larger or the smaller clip, the number of a clip that we can have put inside.
Also the
And
strategy. Yeah.
yes, yes, yes. And then no, this is I want to do this. Otherwise, I cannot go down. I cannot go to the interventional room for that. No. I want that first, the day before or the morning, if the procedure is made in the afternoon, the morning they come with me, anesthesiologist and interventionist, see my images that we discuss together.
Okay.
Max is one of the most experienced echocardiographers here in South America. So Max, show your face, Max. Are you flying, Max, or are you
Oh yes, Max. Hi, Max. we met a lot of time. Max came here in Lugano to give us 7 days, 5 days of course. No, I don't hear.
Turn on your microphone, Max. Yeah, no, we can't hear. So while Max fixes his microphone, I'd like to ask you, Professor Faletra, what do you think about the future in terms of?
Better?
Yeah,
it's better now?
Yeah. Okay, go ahead.
Good morning, everybody. How are you, Professor? It was a great pleasure to hear now, and it was a great pleasure to be there with you. It was a great experience. I suggest to everybody to, if can do it, to do it. I would like to ask about the experience of the operator when you are in or out the Everett criteria. I think the Everett criteria were developed to safety of the procedure at the beginning, and it's still useful to beginners operators. I think that you are going to, you are allowed to go out if you are 100 of procedure. When you are at the beginning, I think that you have to stay on the Everett criteria.
Yeah, you're right, Max. At the beginning, also we just follow the Everest criteria for the first 20, 25 patients. But you know, if you strictly follow the Everest criteria, most of the patients who need the clip, they are excluded. And this is hard in real world are most of the patients which are already behind the Everest criteria. So I don't think that it is also ethical if the patients have a severe mitral regurgitation and you have a system that you can reduce, if not abolish, this severe, don't use because we are outside behind the Everest criteria. Of course, this is maybe more risky, but with experienced operator, the risk is, and I show you with the paper that I showed you, the risk is not increased. And the results are the same.
Because no, but that's the result. But performing, but by a well experienced team.
Yes, Max. This is always in our profession. because if you are a good echocardiographer, you perform better, or experienced echocardiographer, you perform better than the beginning. So every experienced interventionist perform better than at the beginning of intervention. So this is for surgeons, this is for everything. Yes, you have to start with the experienced operator, or have to go together with the experienced operator until you become experienced yourself.
I'd like to hear your opinion about some points about the future. First, about the role of intracardiac echo. Do you think that it may substitute the transesophageal echo, or you think that the TE will continue as the gold standard for a MitraClip guide?
No, my opinion is that TE will continue. If you look at the past, the intracardiac echo was present at the same time that the TE. And but when it was explosion of structural heart disease, most of people use the transesophageal echo for two simple reasons. One reason is that you should have a dedicated machine, and the reason that you should have a catheter, dedicated catheter, which is disposable. So once used, you cannot use anymore, which is a very high increase of cost. The second reason is that the same operator have to use both catheter for structural heart disease and catheter for making the images of structural heart disease. So I don't know how many people is able to do that. Very few in the world.
Okay, and what's your opinion about pre-procedure evaluation using just transthoracic echo? Do you think experienced echocardiography should always do TE, or sometimes?
Absolutely. No. Always. Absolutely. Always. We are talking about the future of the patients. So transesophageal echocardiography is very easy to do. Absolutely.
Okay. Any other questions? Diego is asking, what system are you using for fusion imaging? And congratulating you for the great presentation.
Thank you. No, we use a Philips.
Right. Okay. So Marcelo, would you like to do any other comment? I think we are coming to the end, and let's leave Dr. Faletra to work. He's in hospital, and so.
But they know that I was here.
Good.
Yeah.
At the beginning, it was really an emergency that I cannot escape. But
okay. Any final comment, Marcelo?
Well, I think it's important to highlight a message stated by Professor Faletra regarding the importance to have a teamwork. So it's more and more important to have a synergy between the interventionalist, the cardiac surgeon, and the imager. And it's very important to study previous decades and discuss all the possible strategies. When we do this teamwork, the success of the procedure is almost reached in 100% of the case. Yeah. And you know in advance the difficulties and how to manage intercoherences during the procedure.
Yeah, I absolutely agree with you. In a previous meeting with Francesco Maisano in Zurich, we established that the performance of a procedure is half to half. So alpha is due to the performance of the interventionalist, and half is due to the performance of the echocardiographer. So the echocardiographer is not anymore just a bystanding person inside the intervention, but is really an actor together with the interventionists. And they have to communicate each other. For example, Francesco knows very well the echocardiographic images, and I know very well what he is doing to do. And also with other interventionalists that I work with, I know exactly what they start to do. And then I have on my screen not only the echocardiographic, not only the fusion, but also the fluoroscopy. So I just look at the fluoroscopy as I know exactly where they are with the catheter and so on. So has to be the imagers. I don't care, I don't call anymore echocardiographer, but the imagers who participate to the structural heart disease is another job. It's not the same echocardiographist who do echocardiographer in the echo lab. It has to be a new skill, new knowledge, knowing step by step what the interventionists are doing and so on. So this is another job.
Perfect. So thank you once more, Dr. Faletra, for
thank you to you for
your very didactic presentation. Fantastic imaging. We learned a lot. So thank you very much for being with us.
Thank you.
Okay, be safe.
Bye.